for me, I'll be asking her to advance the slides, so please be patient with us as we do that. Additionally, once we get the OneFusion ID figured out, Hannah will also put up the captions on her screen as she shares. So thank you everyone for joining us today. My name is Adelaide Murray. I know a lot of you. It's really exciting to see you all today. The last time we came together, I was remembering this was one of our last meetings before the entire world changed. I remember Hannah kind of running around with Clorox wipes and the microphones, making sure that we were being as safe as we could the last time we were all together at the New Hampshire Fire Academy. And then I think maybe the week after that, we all went home, or most of us went home. So just, wow, a lot has changed, but I'm glad to see you all here again and glad that we could continue to offer this opportunity for you remotely through these times. So I'm here with my colleagues from the Center for Excellence that are here supporting me, doing a lot of back-end work today. Rekha Sridhara, Melissa Schammel is back from maternity leave. Hannah Lessels and Paul Kiernan were all here on the back end. And then Jamie Powers also joining us from the Bureau of Drug and Alcohol Services as our fearless planning team leader. So today we're here to talk about the doorways. I will skip my kind of housekeeping items about where the exits are and where the bathrooms are, because I hope that wherever you are, you have that information. If you don't, I'm not going to tell you to chat Melissa about it because I'm not sure she can help, but I wish you the best in those endeavors. So next slide, please, Hannah. So what we're going to do today is talk about the doorways. We really wanted to take this time. The doorways have been up and running for quite a time now, and we felt like we hadn't quite given this community the opportunity to really interact with the doorways and kind of dig into the relationships between the treatment organizations, the referral partners to the doorways, and the doorways themselves. So we structured this meeting to hopefully, serve as a jumping off point for that dialogue. So we're going to start with an overview of the doorway model by Don Hunter. Then we're going to have a Q&A panel where I'll be asking 3 representatives from 3 of the doorways some questions that we put together to hopefully, continue to build out that picture. And then we're going to use some poll questions to kind of have you guys direct the conversation, tell us what you want to talk about with the doorways, and thinking about, improving relationships, improving coordination, moving into the future as the doorways continue, which John's going to talk a little bit more about, the future of the doorways and what that looks like. Next slide, please. So in case you are new here, I have seen in our communities of practice that we are getting some newer faces in the remote format. It's easier for people to join, and that's really exciting. And we've been able to transition this model remotely. So if you're new here, the community of practice is a group of people who share the common interest, passion, or concern for something that they do, providing substance use disorder treatment, and who interact regularly to learn how to do it better. In this group, we interact about on a quarterly basis. Typically, as I mentioned, we would be in person. We would come together for 3 hours. We provide you snacks, but the world has changed, as I mentioned. So instead, we're here. We have a bit of an abbreviated meeting via Zoom, but I think it's still going to be a great use of time. So we created it, with the goal of gaining knowledge and sharing information and experiences. The real point of this community is that, yes, we're going to have Don, providing you some information, and we're going to have the doorways answering questions, but we really are here for open dialogue and people talking about what's worked well for them. Really, we're all here to learn together. Next slide, please. So that's kind of what I just said, right? We're here to bring together the substance use disorder treatment organizations, private clinicians, and other providers. We do not discriminate, to gain knowledge and share information and experiences. We do that through a variety of ways, which I'm going to go to the next slide, Hannah. We have all of the resources and tools from this community posted to the Center for Excellence website. So that includes the recording for these meetings, whether they're in person or remote, we record them and they're posted. Throughout this meeting today, Hannah and Rekha are going to be working on capturing all of your questions and also writing out the answers that are provided. So if you hear a question or you didn't hear an answer, the question and answer will be posted on the Center for Excellence website for you to reference back to. We also have other resources Paul has developed over the years, assessment tools and things like that. So definitely a great page to check out there. Next slide. We also have our Google group, which if you're not a member of, you can email me or you can message Melissa in the chat and we'll put you on the list to be joined. So this is kind of like a listserv, but it's just for this community. You can ask questions of people, you can share resources, you can share events. It's a lot of me sending you guys stuff, but that's okay. You can respond sometimes too. That's what it's there for. So just another plug for the Google group as always. And then next slide, please. Oh, so that's that. I'll transition to Dawn. So what we're really hoping to accomplish today, I'll just kind of quickly tell you the objectives before Dawn starts, is that we hope that by the end of today's meeting, you'll be able to list all of the core services that are offered by the doorways, compare the additional services that vary between the doorways, describe the ways in which the doorways are adapting their services during the COVID-19 pandemic, and then also identify resources for community partners and opportunities for collaboration between the treatment providers and the doorways. So with that, I will hand it over to Don.
Thank you. Good morning, all. We appreciate the opportunity to talk with you about the doorways. What I want to do is start off with an overview of the SOAR initiative. Then we'll do a walk through the doorway system from access to services, provide a few data points for your reference, touch a little bit on our public messaging campaign, before I turn it over to three of our doorway leads for their perspective and opportunity to interact with you. We certainly hope to be able to address your questions and generate some discussion that provides us all with takeaways that we can use to improve the SUD system of care. So before I do go any further, I want to dispel some rumors about the doorway status. I want to assure you all that all 9 of the doorways are open and serving clients. They have adapted and continue to adapt to COVID challenges, and I'm sure the 3 of them can talk about that a little further. And I want to point out specifically that the Manchester and Nashua doorways have transitioned to new organizations. But again, they are opening, they are up and running, they are serving clients. And finally, the doorways will continue. Even though our first round of SOAR funding is coming to an end, we've already applied for a second round. And if we have some time at the end, I can talk a little bit more about that. So next slide, please. So New Hampshire has among the highest per capita drug overdose and fatality rates in the country. So when the State Opioid Response grant was issued, we had an opportunity and took that opportunity to obtain very significant amount of funds. So it's a 2-year grant. Again, it started in the fall of 2018 and the first round ends at the end of September. The purpose is to combat opioid crisis in New Hampshire in order to enhance our system for SUD prevention, treatment, and recovery services and supports. We specifically target opioid use disorder. We'll talk a little bit more about that. Other goals include, not surprisingly, to reduce opioid overdose related deaths. And one of the real pushes under the SOAR funding is to increase access to medication assisted treatment. So the SOAR mission, you see the bullets there. We want to make it as easy as possible for individuals, family members, other concerned individuals to access services. We're trying to increase and standardize services, strengthen our existing systems, really ensure access to the critical services. And we know that's a challenge for all of us. And then after moving through the treatment portion of the system, really promote engagement in the recovery process. Next slide, please. So what is the doorway model? First of all, the doorway represents a statewide system with regional access points and a resource network of community providers. As you see here, it's designed to be a centralized and integrated system. We receive referrals from many different origins. Talk about that a little bit later. We provide consolidated information source. We hope to we have and we hope to continue to streamline resources that are available. The doorways continue support and follow through from the treatment in the recovery process. And we provide client-centered community linkages and referrals. The next slide. So, system overview. You see here, we try and focus everyone to come through 211, because not everyone needs OUD services. So the 211 folks are trained to talk with individuals about what their needs are. Then we have the doorways themselves, we have the 9 regional hubs, and then finally, we move individuals into our community network of providers. I'll talk about each of these components separately on the following slides. Next, please. So 211. So the doorways have connected with 211, the existing 211 system, to provide multilingual information and referral 24 hours a day, 7 days a week. So when a client contacts 211, the call center folks there are trained to help talk with each client and help them assess what their needs are. And if it's OUD, doorway related services, then they refer those individuals onto the doorway. If it's housing needs are their priority, they move them into housing resources. If it's a mental health issue that's that individual's top priority, they will move them into the mental health system. So they really are the access portal to behavioral health services. Just looking at my notes. So if an individual is assessed at being at danger, immediate danger to themselves or others, 211 definitely connects them to emergency services right away. You can see we do warm transfer to the doorways. 211 never just gives somebody a name and a number and says, good luck, we hope it works for you. They do everything they can to make sure that there is a direct connection to either the doorways or if it's after operating hours to the on-call service, which we talk about next. So next slide, please. So the doorways operate from 8 to 5 days a week. Manchester and Nashua are working as they're able to ramp up and increase their staffing capacity to have broader hours and days than that. But right now, everybody's Monday through Friday, 5 days a week. So what 211 has available after those operating hours is SOAR has a contract with Dartmouth-Hitchcock to provide on-call, after hours, and weekend and holiday services. So those services consist of crisis stabilization, screening and immediate needs assessment, to connection to emergency services when appropriate. And then the next day or the next work day, the clinician who talks to each individual communicates directly with the appropriate doorway and passes along the information they have so that that doorway can then reach out and engage those individuals. Okay, next slide, please. So here is an overview of the doorways flow. And I'm not going to read through all of these. We'll touch on some of this further. So the first step is the referral. You can see 211, you see the variety of referral partners that we have here. It is quite a range. It's really anybody. Anybody can refer individuals to the doorway. Then you see the core functions. Again, I'll be talking about these more in a minute. The referral to services, you see the list there. It's certainly not meant to be comprehensive. The doorways identify needs and refer individuals to whatever types of services they need. And then there's that important continuing care component, the recovery, monitoring, and some of the administrative functions that the doorways serves. So next, please. So here is our circle of services. You see right at the top, the treatment services, which you are all certainly familiar with. And we have the recovery services, which include our recovery community organizations and a recovery housing component. Then we have our prevention services, which includes a public messaging campaign. We have our specialty populations. Some of these we do have special focus on MAT for pregnant postpartum women. We have a strong program that we work with DCYF for families that are involved with DCYF to help the children and the parents and even the grandparents who are taking care of these kids. We also have a series of programs with the Department of Corrections. We fund care coordinators. Corrections is now doing this, the state level corrections, State Department of Corrections. They are doing beginning MAT induction before an individual is released into the community. And they also provide naloxone kits for those individuals who are re-entering the community. We have our client and administrative services. These are our core services, which I'll get to in a second. The social services, the social determinants of health, our primary care and mental health. We want to make sure we're connected and integrated with those systems as closely as possible. Next, please. So here is where you folks fit in, our community providers, our strong network of existing providers that through SOAR, we are working to enhance and improve capacity to the extent that we can, and we certainly hope to do more of that in the future. So these are primarily the clinical services, and we also have the recovery services and supports. And then, as I mentioned, the social determinants of health, really the primary health care, the doorways identify if someone is eligible for Medicare or Medicaid, but not enrolled. Certainly help with housing needs, food needs, and employment, anything that an individual needs as they move through the treatment and into recovery, the doorways are there to assist with. Next, please. So these are the core services. So it's important to note that the doorways and the doorway staff themselves do not provide any direct treatment services. They provide screening and crisis stabilization, you see evaluation and care planning, help individuals learn and apply for benefits and programs. Depending on assessments that are conducted and the need for services, the doorways provide facilitated referrals to providers. Again, we try and do warm hands off as much as we can so that we don't lose these individuals. And then at post-treatment, there are a series of continuous recovery monitoring. So the doorways keep in touch with the individuals as they move through these processes, because as an individual moves through treatment and moves into recovery, their needs change. And so we try and keep them engaged, continue to identify what those changing needs are, and then assist those individuals to obtain the continuing services that they need. Next, please. So the administrative services that the doorways provide. Really, a key one is the purchase and distribution of naloxone kits. So every individual that contacts a doorway, they're asked, would you like naloxone? Same for if family members contact the doorways. Would you like naloxone for the individual that you care about? We are required under the grant to do what's called GIPRA, data collection. GIPRA is one of those wonderful acronyms that I can never remember, so I won't try. The doorways are responsible for conducting the GIPRA with every individual that they engage with. It takes about 45 minutes. There's a lot of information that's gathered through that. There are A follow-up GIPR is conducted after 6 months, and then there's a discharge GIPR when the individual is completed with services. All of this information, the way we have it set up in New Hampshire, all of the GIPR information is centrally gathered and is automatically sent to SAMHSA every night there's an upload. The doorways also have flexible needs funds. These are to provide for those incidentals, including things like transportation to and from appointments. They use these funds to cover recovery housing while individuals are getting back on their feet and can identify and move into more stable housing. We have added respite shelter funds. We found there was a need for individuals. They would reach out to the doorways and say, I want to get into treatment, but a treatment slot may not have been available right away, or if it happens at night, certainly can't put them into a treatment slot at night. So respite funds are available. We have 2 contracted providers and another provider that's got a memorandum of understanding with the Manchester doorway, so that individuals can be placed in a safe, secure, monitored environment. They can stay there as long as they need to until they can get into the level of care that's indicated through their assessment. Okay, next slide, please. So these are actually the doorway locations. Again, there are 9 regionally located doorways. Berlin, Littleton, Lebanon, Laconia, Concord, Manchester, Nashua, Dover, and Keene. You will note that all of the doorways are now associated with hospitals. We think this is a very valuable connection. The resources and the expertise and those community connections that these partnerships provide are invaluable. Next, please. So here's some data about, this is really high level of SOAR. You can see, now this is through the end of April. The doorways had provided 4,000 clinical evaluations. They provided over 6,300 treatment referrals. The time frame for this, I should step back, from January 1st, 2019, when the doorways opened, through the end of April 2020. Served over 10,000 individuals. Those are unique counts of individuals. Distributed more than 14,000 naloxone kits. We really think this enhanced naloxone distribution process is really making a dent in the overdose deaths. So in the second column, you see SOAR has provided training, a number of training scholarships. In addition to the individuals who receive scholarships, we've had almost 1,000 participants in a number of trainings. We still have some more pending before our cycle is ended. And the bottom line here, we have, through SOAR, there are 53 individual contracts totaling $52 million. It's quite a sum of money. We still have a lot of growing to do, and we're looking forward to receiving our SOAR 2 funding and moving ahead with that. Next slide, a little more data. Oh, this one. So, not surprisingly, the reason why individuals contacted the doorways is primarily opioid related. Also, not surprisingly, far and away the number 2 reason is alcohol related issues. So anyone can go to a doorway for intake and assessment of their needs. If someone has a need that is not opioid related, those individuals are referred to appropriate services that already exist in the community. If their needs are opioid related, then we move them into our set of treatment providers A lot of you are also treatment providers under the Bureau of Drug and Alcohol Services. And if there's not another payer, if Medicaid is not the payer for those individuals, then SOAR will pay for those services. We want to make note that there continues to be marijuana-related, methamphetamine-related, cocaine-related issues. Certainly, you're continuing to see a growth in these. And under SOAR 2, we will be able to expand our coverage to address stimulants, including cocaine and methamphetamines, but unfortunately not alcohol. One more data slide. So this shows the levels of treatment referrals and by quarter how many referrals have been made. So we range from medication-assisted treatment through the various outpatient services, peer recovery supports, and the array of residential services. This is quite an impressive list, but what this list also kind of shows between the lines, and you folks are aware of this, there is a lack of capacity in several areas. And we recognize that, and in connection with BDAS, we hope to continue to increase and improve capacity in those areas as we move forward. Next slide, please. So very quickly, SOAR has funded a public messaging campaign. You can see all the different areas that we've touched on here. There are a variety of printed materials available. You see an example of one in the corner there. If you would like some of those materials, contact the doorway that serves your area, and they can provide you with the business cards, these rack cards, some larger posters. And all of these materials are regionally specific. So if it's somebody in the Concord area, these materials have the address and information for the Concord doorway. We also have an informative doorway website, doorwaynh.gov, that has links to information and resources. We hope to continue to build that to provide more information and better linkages for individuals seeking services. Next, please. We're not going to link on any of these today, but I wanted you to be aware of, we have some great mini vignettes. There are 4 of them, I believe, of individuals who talk about their situation and what they've gone through, and kind of messages of hope and recovery. They are very powerful, and certainly may be of interest as you're working with individuals to reinforce with them that there is hope, recovery is possible. And then the last slide, please. So that is my overview. Adelaide, I don't know if you wanted to open it up for questions yet, or if we want to move on to our doorway leads. What's your pleasure?
Thanks, Don. So we have gotten quite a number of questions in the chat. I think that what I'll do is we'll introduce the 3 doorway panelists, and then as we ask, the questions that we had already identified and the questions that have come in, if it is more appropriate, Don, for you to answer a question directly, even during our panel, please feel free to do so. Does that sound okay?
Great.
All right. So at this point, Hannah is going to stop our screen share so that we can see each other during our discussion. So that means that you will lose her closed captioning services, but Melissa did put the correct OneFusion ID in the chat. So if you need assistance in getting those services on your individual screen, please chat Melissa. And then one more housekeeping item before I introduce our panelists. If you received the link for today's meeting because someone forwarded you an email, check out the participant list on the right hand of your screen. Look for yourself. You should be at the top, maybe below the hosts, our group. But if it says someone else's name, please rename yourself, because for our attendance list, we want to make sure that we're able to capture everyone. So if you kind of hover over your name, there will be 3 dots, and it should say rename, and then we can identify who you are. Those links were individualized to our registration information. So if you shared your link with someone else, they're showing up as you. So just that little note. So now I'll introduce our panelists. So our first is going to be Nelson Hayden from the Keene Doorway down at Cheshire Medical Center. Then we'll have Peter Fifield from the Dover Doorway at Wentworth Douglas. And then we're also excited to have Christine Weber representing the Manchester Doorway, one of the new doorways, so to speak, from, I forgot the hospital, so I'm not going to say the wrong one. There's too many there.
Catholic Medical Center.
Thank you, Catholic Medical Center. All right, so like I said, we got a lot of questions in the chat. I've been trying to make sure that we get them all. So to start, if Nelson, Pete, and Christine just kind of want to do a quick introduction, so people can find you in their screens, see what you look like, and let us know what your role is at your doorway. We'll start with Pete.
Thanks. Thank you very much. My name is Pete Fifield. I'm the manager of the behavioral health services in general at Wentworth Douglas Hospital, and the Doorway Project specifically is one of those programs that I manage. We are located right across the street. We're definitely associated with the hospital, but we're not in the hospital. We're right across the street at 798 Central Ave in Dover. And I think that this is my face. You can find me. Thank you.
Christine?
Hi, I'm the actual Christine. I did forward my invite along.
That's okay.
So I am a clinician. I'm also a consultant that is helping CMC stand up the Doorway of Greater Manchester. And I would be glad to talk about where we are now during this transition. There's some core service elements that would be important for treatment providers to know as far as where we're at in relation to Granite Pathways as a prior vendor and what their services look like, as well as what our services are today and what we're hoping to roll out in the near future. So we have been on site at 60 Rogers Street in the same location as Granite Pathways, so it's very familiar to the community. And we began working out of this location on Monday, May 11th. So that's who I am, and I'm sure we'll get into more questions as the meeting goes on.
Thank you.
Thanks.
And last but not least, Nelson. You might be muted if you're trying to talk to us.
How's that? Is that better? I just wanted people to be able to associate with the face, not the voice necessarily. So, my name is Nelson Hayden. I'm the director of the Doorway at Cheshire Medical Center. I'm also a clinician here at the Doorway. We recently moved from our location at 640 Marlborough Road and are now located in downtown Keene at 12 Railroad Street, where we actually share space with Monadnock Family Services, which is our community mental health center. And already we have been able to have some efficiencies and some referrals back and forth. And so it's good to be able to connect more closely with our treatment providers just by even sharing real estate. So looking forward to talking to you and answering any questions that you may have. Thanks.
Thank you. So the first question that I'm going to start with is if you could speak to the additional services that the Doorways offer. Don had kind of gone over those core services that is shared amongst all of you, but we also heard that there are some additional services that might be more specific to Doorways. Can you give us a general sense of what those services are, what those might look like at the different organizations across the state?
Yeah, I'll go with this one first. We pretty much, are sticking to the traditional core services for the most part. We found for many reasons that we had to provide a level of bridge therapy, which we're describing as very short-term therapy to get people connected. We had significant wait lists for individual therapy, for IOPs, for any level of care. So really that our clinicians sort of engage in a very short term, typically it's actually averaged around 2 to 3 sessions to then bridge this individual till they get to therapy. It's tricky because we didn't want to create a situation where we're creating an alliance with the client, a very close one, yet we wanted to keep them motivated and connected. So, and we also are doing, through our emergency department and Great Bay Mental Health, we're trying to be able to do inductions for MAT within the same day. So they walk in and we can then get an individual, and it's just buprenorphine, to be honest. We haven't figured out how to get same day MAT for Vivitrol yet. But for buprenorphine, we are able to do that same day. So those are really the 2 outlying services we offer here.
Thanks, Pete.
Okay, this is Nelson from Cheshire Medical Center, and I think one of the first things that we also realized was that there was going to be a need for some interim or brief intermittent therapeutic assistance for people with substance use disorders. There, as you know, there has always been a little bit of a wait for people to get into various levels of treatment, and we have found that sometimes the wait is longest to actually get into the lower levels, the 1.0 individual therapy for people that don't need residential treatment or have completed residential treatment. So we are meeting with people and providing that bridge therapy when we can, not when we can, when we have to. And that has been central in keeping people engaged in the process as they await the next level of treatment, which leads to another, tangent off of the core services, which is really more of a wraparound care. We have been really focused on working with the treatment providers, and when somebody finishes one level of treatment, trying to reach out, keep the person engaged, and help them move on to the next level of treatment, whether that be going from residential to a transitional living or to a sober living with an IOP program. We know that treatment providers have aftercare coordinators, and we know that also some people leave treatment at an unscheduled time, and so that that aftercare may have been arrested in mid-process. And so those are 2 of the things that we are doing consistently here at the doorway.
Thanks, Nelson.
As far as Greater Manchester, I can't really say that we have services that are provided outside of the current scope, but one of the main things that we've been able to do recently here is outline referral channels with CMC prenatal care as well as healthcare for the homeless, making sure that there's a broader range of access to waivered providers, much like what Peter has that in-house. But we really don't have the utilization right now that would substantiate a waivered provider having hours within the actual doorway. So making sure that when that's part of a client's assessment, that we're able to have a range within this area. And so far we've been relatively lucky, I would say, having clients being able to use meaningful cell phones. They know someone who has a cell phone, they're able to get connected. But I'm curious, like I'm sure many of you are, what that would look like post-COVID in terms of telemedicine.
Thanks, Christine. And so if, for the other doorways that we don't have represented here in terms of things like MAT and bridge services, folks can connect with the doorway in their area to get a better understanding on the extent of those services at that particular doorway. Is that correct?
Yeah, and I think it's worth saying that Lakes Region has a significant MAT program, as well as Littleton and Androscoggin are doing very well getting folks connected to MAT in a very short term. I don't want to speak for them. I just think that that's worth noting.
Thanks. So in keeping in the vein of services, we had a couple questions come in from people about the Flex Fund services. So first question is, does each doorway get to decide how their Flex Funds are going to be used, or is that something that is kind of directive for you guys?
Nelson, you want this one?
Wow, this seems like it's stepping into a fire, but I would say that we have been given guidance by the SOAR team on what is appropriate use of Flex Funds. We have put together Flex Fund agreements and protocols, and so I think a lot of it has been directed. However, I also think that even in a small state like New Hampshire, the needs of people in Cheshire County may be very different than the needs of people in downtown Manchester, which has a significantly different population. And so when we were going into respite housing, some doorways were utilizing motels. Some other doorways were, like for us, we entered into a contract with our local cold weather shelter in order to utilize some beds of the cold weather shelter for respite beds where people were waiting to get into treatment, which is very different than a hotel room, but also a way that we have been able to work collaboratively with our community. And now our cold weather shelter is actually open more days during the year because they have that contract with us. And so I think there is some ability to tailor our Flex Funds to the community needs, but there is also definitely some guidance.
Yeah, and to that, the guidance is clearly around 6 domains. So it's transportation, communication, clothing, nutrition, housing, and I believe childcare. Those are the 6 domains that we could sort of general categories that we operate under. And then each doorway was, you know, as Nelson was saying, each region has their own very specific need base. So we were allowed to, with state guidance, create our own internal policy around how we would use these. I guarantee if you put them all together, they'd look very, very similar, you know, in ways, in very generic ways, yet specific in terms of, like Nelson having the relationship with 100 Nights. Here in Stratford County and Rockingham County, we don't have a surplus of homeless shelter beds that we could sort of arrange that agreement with. So we had to take a different option for respite. One thing I think is clear is to access the flexible fund usage, an individual has to be connected with the doorway. It's not just, hey, come on in. Yeah, I need a ride. Sure, man, we'll hook you up. So it's really they're connected to our location for at least some level of care. And typically that's seeking treatment. Sometimes it's, I really need help maintaining my recovery. I'm doing really well, but I'm kind of rocky right now and I need a little assistance. And then sometimes it's absolute crisis management that we sort of have to take the next step. So it really varies, and that's the difficult part. That's the significant gray area for every doorway, is sort of how to address this, the individual that you're trying to serve right then and there within these boundaries that we have regarding Flex Fund usage. Yeah, so I hope that helps clarify something. Or
it does. It transitions well to the next question on Flex Funds, but I don't want to cut Christine off if she has anything to add. So Pete, you kind of walked us right into the next question, which was, if we have a client who would benefit from the use of Flex Funds for housing, transportation, etc., what is the best way to connect them to those resources?
With our doorway, it means that, well, the GIPRA, I think the GIPRA stands for Global Performance Rating Assessment. It's a SAMHSA acronym, and it really is, it's a survey, right? That SAMHSA attaches to every dollar that leaves the doorway. So anyone that it wants to be connected with the doorway, and access flex funds, we have to do the GIPRA. If it's outside of opiate use disorder, we don't have to do the GIPRA because that's not what the contract dictates. That said, any use disorder, I believe, and I'm speaking for all the doorways, we will help connect anyone with any level of any use disorder. So the flex fund access, though, only comes right now with a primary diagnosis of opiate use disorder. So what an individual, to answer the question, an individual has to connect with the doorway. We have to perform a screening process and go through and complete the GIPRA. And then at that point, it's whatever the client needs are. We sort of then triage where to go from there. So that's how you would get connected to the doorway for flex fund usage. Nelson, do you want to just talk about generic connection?
Yeah, and I think that it's interesting to hear. I've been in a number of presentations with Pete, and it's interesting to hear him say it all revolves around the GIPRA, which is actual fact and very important to the SOAR team. Pete is a much better politician than I am. But when I talk to my staff or I talk to a referring party, I say people have got to be engaged in the doorway program in order to have any access to flex funds. And for us, we talk about the ASAM, which is the assessment. We do an ASAM and a GIPRA right at the initial session with a client. And so I could have said, yeah, it all revolves around the GIPRA, but we just use the term ASAM for it. But what that means is the person is engaged in services. The person is actually seeking things other than transportation or other than a bed somewhere. Because I spent a number of years in the hospitality industry, and we are not in the business of transporting people or providing beds. What we're in the business of is facilitating access to treatment for people with substance use disorders and keeping them safe until we get there. And that's what the flex funds are really used for. You can always reach us through 211. We've also reached out to many of our local referring partners and treatment providers so that they have a way to get in touch with us in case something is emergent and they need to connect a client with us because they need a higher level of care, they need a lower level of care, whatever that would be. So I hope that helps.
Christine, do you have anything?
Yeah, I would, want to point out for certainly Peter and Nelson, the other doorways that are probably fielding these calls as well, is that the Manchester doorway has not distributed any flex funds as of this date, coming up on a month now. But we have fielded quite a few calls, and I think that those calls really speak to what both Peter and Nelson were sharing around making sure that we're managing clients' expectations about eligibility and not just criteria for being a doorway client, checking that box to be able to receive funds, but what else needs to really go on, right? We wouldn't just toss a client a prescription and walk away either. So part of this is making sure that if they're looking for flex funds to enter into a sober living house, that they're connected with some other level of care, and that's important absolutely in this region where we have so many services popping up all over the place. So understanding the client's expectations, understanding what other resources they have at their fingertips that they might just need some help navigating, like CTS rides. That's something that we've been doing quite a bit over the phone.
Yeah, no, absolutely. Thank you, Christine. And that leads me into sort of what the doorways are. We're stewards of the government's money, right? And we are really trying to balance two things. One is create a structure that is clear and concise and guided, and provide services for an individual. So we've had a number of calls. We get them every day. Hey, can you get me a ride? what's your name? You know, who are you?
Yeah.
And a guy came in just yesterday at 4:50. I heard you guys can get me to my home in Concord. You know, I was like, okay, so there are expectations that we have to consistently manage.
Yes.
Engaging in doorway services, I think, is sort of a way for everyone to sort of format what does it take to access and utilize and get this financial assistance. You have to be engaged with the doorway for services. So I think that helps sort of not only guide the referral, but very clearly, as Christine said, guide the client's expectations. Because they get mad at us. We're like, no, I can't pay your rent this month. And they're like, oh, someone told me you could. And it was like, so it's that expectation that not only, I don't think it's our responsibility, I think it's everyone's responsibility, because ultimately it comes down to the client being very disappointed, disenchanted, potentially, disheartened. So.
A couple more questions about more of a logistical aspect of the doorways related to hours of operation and how after-hours service works. So the first I'll ask is, are there any plans to increase hours of operation? Are the doorways, are there some that are open past 5 p.m.? I think Don touched on this, but can you give us some more details?
Yeah, I mean, Don touched on this for Manchester and Nashua. I can't speak for Southern New Hampshire, obviously, but here at Manchester, we are what I would consider fully staffed for the volume that we have experienced thus far. The staffing pattern could change. Certainly the days might change, but one of the considerations for expanding hours in Manchester that I want to be mindful of, CMC wants to be mindful of, is we can't be the only doorway with major hours, in the state. We're already, arguably the most resource rich, but we're also really inundated with a lot of people that are very high risk and high need. So part of the concern is safety and security, and making sure that we're not opening our doors and not able to provide meaningful care to these individuals. If we were to expand on Saturday and Sunday, there's a real lack of availability for clinical assessments on those hours. So again, we're in that position where our doors are open, and then the doorway becomes this drop-in center without real clinical care, and that's not ideal for anyone from my perspective. So are there benchmarks and are there dates? I think for expanding the Manchester hours, it really relies on what's available in the community. Which again, going back to what Peter and I have been talking about, that's everyone's responsibility, not just the doorways. But right now, to my knowledge, there is no department that's open beyond Monday through Friday and 5 p.m.
Right, and this is done, and certainly we recognize that life doesn't stop at 5 o'clock on a Friday afternoon, that people have needs and need to at least get some kind of support whenever they're ready to reach out for it. So have been communicating with the doorways. We've been working closely with the governor's office, with all of our partners within the Department of Health and Human Services, and we're trying to come up with, based on regional needs, the best way to have some contact and some engagement available as close to 24/7 as we can. So we all just stay tuned for how we're able to work that out going forward.
Another question about after hours is, since Dartmouth is staffing the after hours and offering crisis stabilization, are they fully educated on all of the services available in all areas of the state?
I would say that they are. I can really only speak for the information that we receive from after-hours calls to Lebanon, but when we get an email that indicates so-and-so called, this is what he's seeking, and the expectations are clearly laid out there of exactly what the individual is searching for. They have already indicated to the client that somebody's going to reach out from the doorway at Cheshire, because when we called, they're like, oh, this is great. They told us you were going to call first thing this morning. And they seem to know what the doorway is at Cheshire. And they're, the people that are working for Lebanon are clinicians, and so they are able to provide that interim support in the overnight hour that was required for that person or that family member in order to make them feel comfortable and tide them over until the next day. I really think that that service, the way that it's been conducted, has really been a plus for the doorway. I don't know, Pete, Christine, what your experience has been, but mine have been nothing but great.
No,
Yeah, I would agree with that.
It's been very good. We get a fax every single morning that comes to our private secure line that has a clear rundown of what was addressed, the name, the individual, a contact phone number, and expectation. Is a very clear outline. And then we communicate with them the next day. And as Nelson was saying, you know, they're like, oh, I was waiting for you to call. And it's like, great, all right. You know, so the expectations are very clear. I think it's absolutely impossible for one clinician in Lebanon to know every psychosocial bio service in the whole state. I mean, that's not even an expectation I think that's realistic. However, being able to sort of connect them to the urgent resources at that time, they are able to do, and they do very well, so.
Yeah, I've had a similar experience, and you know, they're referring to a hub's region because it's really the hub's responsibility to be aware of their region services as well. So it's been pretty collaborative, and it is the doorway's responsibility to keep 211 and via DH advised when there's changes or new programs. But it's difficult even with this, you know, within this area, and I assume rural areas as well, to get specifics around hours of operation, particularly now. But I haven't run into any caller through 211 that was given, you know, precise information. It changes daily for providers in this area, just based on staffing patterns, but great information from them.
Thank you.
And as we're talking about this in the after hours, I have done like a SurveyMonkey survey to assess how our clients feel about our services. And one of the questions that we asked was, what could the doorway do that it's not currently doing? And one of the leading responses, not the leading response, but they wanted more help with education and training. They wanted help with employment, and they wanted more MAT services, which Don's already highlighted that we're doing a lot of MAT services. Those were the top three, but then the fourth one was weekend or evening hours. And so we asked, what weekend or evening hours would you want? And of those weekend and evening hours, mostly what people wanted was the 4 p.m. to 6 p.m. They wanted that, excuse me, extension of a day just by an hour or so. And then some people also wanted weekends, but we asked if people would like 8 to 10 p.m. or something like that, and there wasn't any demand for that. And so I think letting that go to an overnight service is okay.
I want to be sure to get to the question about the COVID-19 pandemic and how have services changed at the doorways. You said that you're all still open, so that's fantastic, but have there been new services added, or how have the doorways adapted to continue to provide services to folks during the pandemic with all that's changed in the way in which treatment's being delivered?
I'll answer that first if you two don't mind. No? Nelson, you good? We've been open since the beginning of this pandemic. We've maintained being open. For social, I call it physical distancing purposes, we've trimmed down significantly, and we're following all hospital protocols. However, we continue what we tried to do was we're asking everyone to call first, right? Because if people call first, we can manage an expectation, we can manage a wait list, we can manage a social distancing sort of protocol. Keeping in mind that even if 80% of the individuals call first, we still have 20% walking in. So that's really why we're asking folks to call first. However, we still are engaging with individuals face-to-face, and we have been since day one. We've had a huge, significant uptick in our Zoom or our, what do we use here? Yeah, it's a Zoom platform for virtual visits, and those have spiked significantly. We've done a good number of virtual assessments with individuals. So that's a significant plus for us, I think, just in our state. We've got a huge access issue. And if we can access an individual and sort of complete an assessment via Zoom, that's just a wonderful advantage. Yeah, so I wanted to point that out because we do continue to see people. However, we as a specific doorway, and I think this would work well for everyone, but I won't speak for them, call first so we can navigate and manage that expectation of the individual. Because it's really hard. We have a smoking area out back, and we have a ramp that has like 6 feet apart, but we don't want people waiting outside the doorway 6 feet apart. You know what I mean? And realistically, my experience is they wouldn't do that anyway. Most people aren't doing that. So professionals are, but I see people all the time. You go into Walmart, you go into Home Depot, folks, there's a good number that just aren't doing it. So we're trying to manage a lot of that just on the upfront by having a phone call first so we can schedule an appointment for someone. We all know that individuals don't always make that appointment, so we're very flexible with if they miss their 10 o'clock Zoom call, we'll call them back and be like, hey, can we set up an 11 o'clock? Or if we have some freedom now, we can sort of schedule that right now while we're engaging with you on the phone. So those are the major adaptations that we've made at our site.
Thanks, Pete. Other things to add?
I would I would agree with the expansion of services through telehealth has been, and I think we're preaching to the choir here. I think everyone in this call has probably expanded into telehealth in some way, shape, or form because we've had to. I think we've all been talking about it for a number of years and how this could be beneficial, and it took a pandemic to make us actually, okay, we're going to do this. We have remained open in doing face-to-face assessments and sessions with our clients. The doorway came out with a slogan, "You're never alone and never far from help." And what I felt like initially as the hospital and the doorway were talking about, are you going to continue to provide face-to-face services? I said, this is kind of what the person in need really needs, is they need a warm body in order to be able to feel connected. Some treatment providers, some of the people that we referred to did have to close for short periods of time, or some of them are closed for longer periods of time, and so being able to provide that connection was critical. That being said, yeah, you're going to wait at the door, and we're going to take your temperature, and we're going to ask you some COVID-related questions before we put you at risk. You're going to wear a mask. We're going to wear a mask. My hospital says that they have to wear level 2 mask. We wear level 1 mask. If we're within 6 feet of them, we also have to have a face shield. There's all sorts of different protocols that we go through, but the telehealth, and I always thought that we weren't doing enough of it, but of the new patient visits last month, almost 16% of our new patient visits were done completely virtually. And so that's huge for us, that it takes 2 apps to download onto somebody's phone in order to get them engaged in the Dartmouth-Hitchcock telehealth system. I thought that was huge. And so it's been good.
Great. So I wanted to ask a question that came in that kind of loops a little bit back to connections and referrals. So someone wrote in, I'm just going to kind of read it. one thing that's confusing for our clients who are already connected with our outpatient treatment but need a higher level of care is that clearly the outpatient providers could refer directly to that higher level of care, but if they do that, right, then they're not connected to the doorways, not eligible for the flex fund support and all of the services you all have shared. So can you help me reconcile when it is and isn't appropriate for an outpatient provider to refer to the doorway for support and referral to a higher level of care versus just do it themselves?
I can take a stab at that. This is a relatively I don't want to say a common call that we receive, but it hasn't been rare either, where a client is already connected in services, be it at an OTP or an outpatient department, or they are in a PHP and they're just not able to really realize the benefits of that level of care for whatever reason. And they have either been honest with their current provider and were referred to the doorway, or they have not yet disclosed to their current outpatient provider that they're struggling, and they're really looking for an assessment. So what my guidance has been to clients in that situation, just doing care coordination and consulting about their unique situation, is to really refer back, talk about what their options are, make sure that I have a good understanding of what they view their needs to be, and what the barriers have been in connecting with their own outpatient provider. If an individual is looking for flex funds, it's likely not for a higher level of care. So if they're looking for flex funds that might cover a copay, a deductible, if they need transportation to that higher level of care, it's typically not a flex fund situation, at least not what I have come across yet. But I'm sure, with my limited experience, that Nelson and Peter have had other instances where it absolutely makes sense for a treatment provider to refer to a doorway. I have not seen where that channel tends to make sense in this area, but that's been my experience only. So
I have a few things to add to that. We sort of have created really strong relationships with a lot of local providers, our community mental health, the FQHCs, the IDN, and we sort of have created relationships with an MOU and a BAA to sort of facilitate the connection of the individual to the flex fund need. So if an individual's over at Goodwin in Somersworth and we're trying to coordinate something around that individual, we have taken through the MOU process, we're like, okay, so you have clinicians, you have MLADACs on staff, right? We understand that your assessment of need is very accurate. How can we then connect that individual in a timely basis to this GIPRA thing? So we're like, okay, so that's not always the easiest process for sure. It really can get clunky in terms of who's calling who and when. However, we put a lot of effort into supporting the client and the satellite, for lack of better words, the spoke. From the get-go, we were really operating under the sort of the philosophy that we are here to support the existing spokes. The spokes are doing the service. How can we best support them? And I've sort of morphed that conceptually to we are here to help the client. So, because that's the reason the spoke is here, right? So ultimately, the hub and the spoke are here to help the client. So what do we need to do to help facilitate that? And it does take a lot of sort of fact finding, if you would, to get a clear picture of what's actually happening. And I'm not just talking about our clients. Not everyone in this world is 100% transparent. And I'm not ready to tell you this information yet because I don't know you yet, right? So we're trying to remove that and follow the guidelines to help individuals get to their level of need, help the spokes support getting that client to their level of need, and satisfy the bigger picture of the GIPRA and the federal standards and all that. And I know that sort of sounds vague, but that's really sort of in a clear picture. We would work with the local spoke location to get a GIPRA completed, get them connected to the doorway, and then have them be able to access that fund.
And I would just add to the answer for this question is I know as an outpatient provider that you're busy. You've got a number of clients, and when something isn't working with a particular client in order that they need a higher level of care, if you could pass that off to someone and let somebody else spend the 4 hours and doing an assessment, making the phone calls, making the referrals, coordinating all of this, how many more people can you help in your practice while we address this individual that needs a connection to a different level of care? This is what we're doing on a daily basis, is making this connection and providing this interim support. And so the higher level of care providers are used to hearing from us. I would go back to actually each of our clients can call any level of care themselves and be connected without the service of the doorway.
Right.
There's a part of me that says, yeah, you could do it on your own, but that hasn't been working. And what does that individual do when they're told they're going to be put on a wait list and it could be a week? Whereas if the doorway is going to follow up with interim clinical care and facilitating possibly access to get a physical in order to get into residential treatment because we're all affiliated with hospitals, how many of those services can we just do in a more efficient manner?
So right now there are a couple of questions that we haven't gotten to, but what I'm going to be sure to do is, I mentioned at the beginning of the meeting that we are capturing all of the questions and all of the answers in our question and answer document. So what we're going to do is make sure that the questions that we weren't able to answer verbally right now do get answered in writing in that question and answer document, and it will be disseminated back out to you. But with our last, couple of minutes, what we wanted to do was try to figure out, open that two-way channel. So you've been asking a lot of questions, they've been being answered. But the doorways are also interested to hear how your experiences have been as the system, as the provider. So I'm going to launch a poll on the screen that's going to kind of ask you, it's not it will ask you of a couple of topics of, perhaps you might think about it as what has been most challenging for me in working with the doorways. That's what I want to talk about, or just this is what I have the most questions about that I don't have as much experience with. So I'm going to throw the topics up on screen, and because we want to get a sense of where your head's at in terms of conversation with the doorways, and then open it up for a couple of minutes to share some of your experiences and inform the SOAR team and the doorways about your experiences. So the question's up. There's 4 choices, to speak to your experience working with the doorways. And so I will give you some time to read through those choices and answer the poll. The moment when you all finish reading. We're almost at about half of you answering, so we'll keep it up. We hit 50%. We get a couple more. Nice. All right, I'm going to give a 10-second countdown, last chance to provide that feedback. All right, so you guys didn't make it easy. I'm going to share the results so you can see. So the result that got the most people, 13 out of 33, was coordinating case management with the doorway. However, as you can see, you know, we had a pretty even spread on our other topics. But I am going to go right now with the one that did get the most, even if it was only by a couple of votes. So I do want to open it up to the treatment providers right now to talk about, have there been challenges? What are your questions? What do you want to know from the doorways about case management? And this is not necessarily to say that we're going to solve this right now in the next couple of minutes, but we're going to start to gather that information and like I said, open that two-way channel of communication. So in your Zoom, you can use an electronic raise hand feature. On the right-hand side, there's a little blue hand, and if we see your hand raised, we can unmute you and you can start talking. If you have your video on, some of the folks on, like Jan and Heather, know I'm pretty good at seeing your visual cues. If you want, and Brandy, no. If you want to physically raise your hand, I'll look for you there. And as always, if you're not able to speak, the chat function is there. So the topic of care coordination with the doorways, what's confusing there or what's challenging there for the treatment providers? Those same folks also know that I'm real good at waiting. Shannon, do you want to go ahead? I think you can, yep, okay, great.
Yeah, I think just one of the questions I have is I've had clients, I'll say, have you spoken with the doorway for different services? And they'll be like, oh yes, I'm waiting for them to call me back or follow up and things like that. And so, of course, with a lot of our clients are doing telehealth visits with us, we're not able to get those signed releases of information from them. So I'm just wondering how that might be able to be addressed when a client does do an initial assessment with someone at the doorway, if they can, if part of their workflow is to get releases of information signed so that there's an automatic way for me to follow up with them. Because actually my patient did say, oh, can you call them? Oh, you probably don't have a release of information. So that's just one of the things that I think would be helpful, just to make sure we're not duplicating, work. Thank you.
That's a great suggestion, Shannon. And I meant to say that the doorways and Don, the SOR team, are looking for ideas such as that as they look forward into planning for the next year. So if you said, boy, it'd be really great if you guys could, now's the time to share a lot of that feedback. So thanks, Shannon.
Adelaide, would you like me to answer that question? Or are we just letting questions?
Sure, if you have an answer.
Well, no, and I think I can speak for all of the doorways in this. We do our best to get the full spectrum of individuals that are engaged with that client. It's not always that straightforward. Oh, I've got a clinician. What's their name? Barbara? No, it's not Barbara. It's, so we don't always get the cleanest picture with detail, but we absolutely doorway wide try to get as many collateral supports as we can because we know we have to facilitate that process.
Thanks. What else is challenging about case management with doorway clients or in figuring out how that process works? I know for at least 13 of you, it's your top concern. So I am here to hear that. Don't forget about the chat box. Oh, I might have forgotten about the correct chat box. Heather, did you want to add something? Or did I call on you? Your face makes me seem like maybe you didn't have something to say, so I'm sorry.
That's okay. I didn't, but that was something that I did ask in the chat earlier, and I think some of it was answered in terms of how can we work with our local doorway in Nashua to kind of utilize the flex funds with some of the clients we're seeing. And I heard Nelson also talk about how we could work with potentially the doorway in helping to connect people to higher level of care when we may not have the time. So, you know, working together in the case management side of things is something I'm interested in learning more about.
Thanks, Heather. Sorry about that.
It's okay.
Sometimes I'm too good at looking for those visual cues. Are there other things? So I did kind of go with our top topic, but is there other things related to these other topics? You know, these were identified by the doorways as things that they're curious about. So I hope that they don't mind me opening it up to hear your feedback on any of these things, on accepting their assessments, on connecting back, closing that referral loop, on communication. Now is really the chance to kind of to share that experience on any of these topics.
Well, the way I see three of those questions, the bottom three, they're all related, right? So communicating, coordinating, they're all connected to how do we sort of assist an individual through a complex system with multiple needs, with multiple people, and a lot. It's not easy. However, a lot of this comes from being the provider entities in the community being aware that the doorways exist and being like, hey, have you communicated with the doorway? Maybe I can get a release from you, and maybe use DocuSign or something, you know, more technical, sort of technically advanced than we have with pen and paper. There are lots of options. The other side is the doorways being aware that we need to do our diligence in sort of being like, who else are you connected to in the community? You would think it's that simple. However, sometimes we ask people, have you ever been connected to another doorway? And the answer is no, but they have. So we're really sort of, and it depends on the client's presentation at the time, right? So if they're in withdrawal a day out, they're not great historians, and we'll give them that. You know what I mean? It's like, absolutely, you're not. So it depends on the sort of level of need that the client's in during presentation. But I think all of these, the closed loop process takes a universal commitment. Like everyone has to be willing to be like, oh, right, we need to communicate back to this person, because we did an internal project with the hospital on sort of how do you facilitate better referrals, and we were going to be held accountable for the outcome. And it's like, we're only accountable for 50% of it, right? Because it's the other side that needs to communicate back. So it's realizing that everyone on this call has a commitment and a need and a responsibility to close that loop. It's not just the doorways. We're doing our best. However, we can't do it without the assistance of everyone else. So.
We got a question about how many times the doorway does outreach for a client if they stop following their case management or they stop responding. And then also, does that vary if the person is pregnant?
Go ahead.
Sorry, I don't know if that was Nelson. Well, what we've been doing is outreaching daily if the client is not yet connected to services. We're not providing interim services on site because we've subcontracted our clinical services. So as far as individual outpatient or telehealth in an outpatient group basis, that's something that's been subcontracted and not provided here. But case management and outreach as the client has been engaged in care really depends on where they are. If they're available and in a controlled environment, we have a consent, we're able to verify that with the provider. If they're working on an outpatient basis with a provider, we try to connect both with the client and with the provider. So we have more of that picture. If the client's reporting that they missed a session because they were working or they weren't available and the provider says something completely different, then we're able to kind of reconcile that and document maybe more realistically where that client is at. Does it vary if the client is pregnant? Not necessarily, other than their scope of involved providers tends to be a little bit broader. So we have more people that we're able to connect with.
Nelson, did you want to add something there?
Yeah, I was just going to say that it depends a lot, and I would love to have. I think this is one of the biggest opportunities that the doorway has for the state of New Hampshire and for all of the treatment providers is if we could be that mortar that connects all of the treatment providers, and we had the releases of information and we knew that the person was seeing Cynthia Whitaker, and so we knew to communicate to that individual what their progress was at Phoenix House or something like that. If we could get there, and it's going to take a long time. I mean, we're talking about developing a system of care with a bunch of disparate providers, which is more difficult, right? And then we're going to throw into it that we're addressing substance use disorders, and so we've got a lot of ambivalence going on there at the same time. And so it's a difficult process, but we are trying to reach out to the client. I mean, we do reach out to the client on a daily basis as they get into, as they await treatment, because that's what we've contracted to do. But once they get into treatment, we can't call over to a residential treatment provider on a daily basis and say, hey, how's he doing? Or to an outpatient treatment provider, for that matter, hey, how's Billy Bob doing? Because I haven't seen Billy Bob since last week. Don't call me every day. And so we have to have that appropriate level of communication. And it's a two-way street, and we'd love to have you guys engaged in it as well.
Thanks, Nelson. I'm just going to go ahead and put up our last poll because clearly there were a lot of questions that we could have kept asking and conversation we could have kept having. And so we really want to understand now is if this is a communication channel that you would like to keep open. So the poll that I'm about to show you asks, are you interested in participating in continued conversations between the doorways and the SUD treatment providers? I'm not going to publicly share these results when you guys finish answering, so please be honest, because this is going to inform future opportunities that we potentially could offer. So tell us the truth here, please, and that will just be shared amongst our planning teams. As you're answering that last question, I'll give you a couple of our housekeeping items as we're reaching the end of the meeting. We had kind of planned this meeting thinking like, yeah, we'll shorten it, 90 minutes will be good. And then Reka sent me a message during it of like, I guess we could have gone longer than 90 minutes. So we definitely recognize that and hope that this question, can help guide that decision making. Following this meeting, you will get, as I said, the questions and answers disseminated to you more urgently or frequently, probably either this afternoon or on Monday. You'll get an email from me with your evaluation for this meeting. We do have continuing education credits for MLADACs, LADACs, and CRSWs. But also, please fill out an evaluation. Now we have a new remote evaluation process, obviously, so I'm going to send you a link. And then when you complete filling out your evaluation, you'll be automatically redirected to a form where you'll put in your name and your credentials, and your certificate will be automatically emailed to you. But the survey is still anonymous. What you put in the Google form does not at all tie to your evaluation. So again, another place to please be honest with us and let us know your feedback. As always, I'm always here for questions. Usually I would put my email up, but maybe Melissa, if you can chat my email address into the chat really quick so people can grab that. And other than that, I think that those are most of my housekeepings, our CEUs, our evaluations. I want to thank our presenters for coming today and answering all of our questions and continuing to answer questions that I'm going to send them via email, and all of you for your engagement and your questions. So thank you, everyone. I hope you have a nice rest of your day. Stay cool, have a lovely weekend, and stay safe and healthy.
Thanks, guys.